now we'll talk about a very interesting and a very important topic from the point of view of your exam, that is minimally invasive surgery or laparoscopic surgery. A lot of questions have been asked from this module in various entrance exams, and it is very important for the college exams as well. Now, the first thing which we need to discuss is that why did surgeons go from making big open incisions to minimally invasive work? What was the need for that? So the need for minimally invasive surgery arose because you wanted faster recovery. People wanted faster recovery, shorter hospital stay, they wanted less pain, they wanted the incisions to look cosmetically better. And the surgeons wanted better magnification and better view. So all these things are satisfied by minimally invasive surgery. So these are the advantages of minimally invasive surgery, which has made it so popular over the last few years, right? Now, minimally invasive surgery, before we talk about the details and how we go about it, in Bailey they've given that the basic components of minimally invasive surgery can be remembered with the mnemonic IV TROS. Now, what exactly does this IV TROS mean? I stands for insufflate. You have to create pneumoperitoneum first. V is for visualization of the structures. I is for inspection. Once you've done that, you inspect the structures. T is for triangulation. Triangulation is a very important concept when we talk about laparoscopic surgery. I will talk about this later as well. But in short, triangulation means that when we are doing laparoscopic surgery, I'll show you the instruments later on, we do it in such a way so that the instruments don't clash with each other. We have to triangulate, so we come from different directions so that we can do work with 2 or 3 instruments without clashing with each other. That is the principle of triangulation. R stands for retraction of tissue. O is for the operation, and S is to seal the wound after we've done the surgery. So these are the basic principles of laparoscopic surgery which can be remembered with this mnemonic. Now, I told you the first principle of laparoscopic surgery is to create pneumoperitoneum, that is to put gas inside the abdomen. But if you read the history of laparoscopic surgery, it's actually quite interesting. So in China, they decided to do something new. And sometimes you know that Chinese can have eccentric ideas. So what they did was that they anesthetized the patient, they put hooks on the abdominal wall, and they hung the patient from the ceiling, right? So what happened was that the abdominal wall got lifted up. And once the abdominal wall got lifted up, they put these instruments inside and they did their surgery. Gradually, over a few years, they realized that there is a more humane way of doing it, and that is by creating pneumoperitoneum. That means you put in some air inside the abdomen, and that will distend the abdomen, and you can easily put in these instruments. Now, the question arises that for pneumoperitoneum, which is the best gas which is available, and which is the gas which we are commonly using? So for pneumoperitoneum, the gas which is used is carbon dioxide. That is the gas used. We don't use air. We don't use oxygen. Why is that? Because air and oxygen support combustion, whereas carbon dioxide does not. And if you're using a combustible air inside the abdomen and you're using the cautery, there can be a blast inside the abdomen. And in addition to the surgery, you'll end up with a tandoori liver and a tandoori gallbladder, which you don't want. Right? So no air or oxygen. We use carbon dioxide. Sometimes nitrous oxide has been used. In some cases, nitrous oxide has also been used, but for all practical purposes, it is carbon dioxide which is used. Now, what is the amount of pressure which we achieve when we are insufflating the abdomen with carbon dioxide? So the pressure which we want to achieve is 10 to 14 millimeters of mercury. For abdominal surgeries, 10 to 14 millimeters of mercury, and 5 to 8 millimeters of mercury when we are doing mediastinal surgeries. When we are doing mediastinal surgeries, 5 to 8 millimeters of mercury is good enough. Now, when pneumoperitoneum is created, there are some effects of pneumoperitoneum on the body, and this has been asked as a very common short note in your college exams, and also MCQs have been asked from this. So let's talk about the physiological effects of pneumoperitoneum. So the physiological effects of pneumoperitoneum, the first thing, when we achieve pneumoperitoneum, there is peritoneal stretching. And when there is peritoneal stretching, this leads to vagal stimulation. So there is peritoneal stretching when air or CO2 goes inside, and this leads to vagal stimulation. Now, you know, when there is vagal stimulation, what is going to happen? There's going to be sinus bradycardia. So this is going to give rise to sinus bradycardia, and this question has been asked many times in the exam, that what is the most common arrhythmia seen during minimally invasive surgery or laparoscopic surgery. So this is the most common arrhythmia seen in laparoscopic surgery. This question has been asked a couple of times in the exam. Now, after this, what happens, that when there is increased intra-abdominal pressure, you know, when there is increased intra-abdominal pressure, the IVC will be compressed. Right, so this is going to put pressure on the IVC. And when there is pressure on the IVC, what is going to happen? Venous return is going to be hampered. So venous return is hampered. Now, when venous return is hampered, you know that cardiac output is heart rate into stroke volume, and stroke volume is dependent on your end diastolic volume. That means how much filling is happening in the heart, how much blood is coming back. But if the stroke volume is reducing because of pressure over the IVC, venous return is reduced, so the stroke volume is going down. And because of this, the cardiac output starts to reduce. So how will the body compensate? The body compensates by increasing the heart rate. So initially there is brady followed by tachycardia. Initially there is brady followed by tachycardia. There can also be hypotension. In fact, you must have seen that as soon as pneumoperitoneum is created, after some time, if you see the BP reading on the monitor, there can be hypotension at that time as well. Now, if it's a prolonged surgery, the CO2 can get absorbed. CO2 gets absorbed, and this can even give rise to metabolic acidosis in the long run. If it's a very long procedure, it can give rise to metabolic acidosis as well. This has also been asked in the exam. Now, pneumoperitoneum, when you have gas inside the abdomen, that's going to push the diaphragm up, right? So diaphragm is pushed up, both the domes of diaphragm is pushed up. Now, it's common sense that when the diaphragm gets pushed up, what happens to the thoracic volume? The thoracic volume reduces. The intrathoracic volume is going to go down, right? But the intrathoracic pressure is going to increase, right? Volume reduces, but the pressure increases. Now, what is the significance of this? If the volume is reducing, then all your lung capacity, tidal volume, everything reduces. So tidal volume reduces, total lung capacity reduces, vital capacity reduces, functional residual capacity, everything reduces. Why is this significant for me? If you have a patient who is a cardiac patient or a patient with severe COPD, then a reduction in these volumes can be detrimental for these patients, which is why for cardiac patients and COPD patients, we have to be careful while doing laparoscopy. We have to be careful while doing laparoscopy so that these volumes don't suffer too much. So this is important for your exam. That is why before a patient undergoes surgery, the PHC, the anesthetist, looks at all these parameters before deciding if the patient is fit for laparoscopy or not. Now the intrathoracic pressure is increasing. So what is happening? The airway resistance increases. Because of this increased pressure, there is increased airway resistance. In simple terms, what does that mean? If there is increased airway resistance, more pressure is required for air to go into the lungs. Right? There's more resistance for air to go into the lungs. So the anesthetist has to push air with more pressure. And because of this increased airway resistance, our anesthetist has to use increased PEEP during laparoscopy. PEEP is peak end expiratory. PEEP is peak end expiratory pressure. This is to be used to make sure that air enters the lungs. The third thing which you need to remember is that when there is pneumoperitoneum which is created, it will also put pressure. Pneumoperitoneum also puts pressure on the renal artery. Also puts pressure on the renal artery. This is going to lead to decreased renal blood flow. Renal blood flow is going to reduce, which is going to lead to decreased GFR, which leads to decreased urine output. And more prolonged the surgery, more is this effect seen. Now you also know that if there is decreased renal blood flow, then which system is activated? Correct. The renin-angiotensin system gets activated, RAS or renin-angiotensin system. And you know that the end product of renin-angiotensin system is aldosterone. So there is going to be increased aldosterone which is going to be there, and this will lead to sodium retention. Again, if this is a prolonged surgery, this effect is seen more. Another thing which you need to remember in pneumoperitoneum is that it also increases the intracranial tension. The intracranial tension also increases. This question has also been asked 4 or 5 years back in the exam. So these are the various physiological effects of pneumoperitoneum which you should remember for the exam. It's been asked quite frequently. So once we've discussed this, now we have to discuss how will pneumoperitoneum be created. So for us to create pneumoperitoneum, there are two methods. Now to create pneumoperitoneum, we can either have the open method or we can have the closed method. So pneumoperitoneum, you can either have the closed method or you can have the open method of pneumoperitoneum creation. The closed method is using a Verey's needle. This has been asked many times in the exam. A Verey's needle is used for creation of pneumoperitoneum. What exactly does a Verey's needle look like? So this is what the Verey's needle looks like. You can see here, this is a Verey's needle. This is what it looks like. This is the actual Verey's needle which you can see. Both the image and this one is different. There can be different types of Verey's needles. But what you will have in a Verey's needle is a beveled edge. There is a beveled edge, and I have demonstrated in the instrument module how this beveled edge works. So for details, you can look at that module and see how this beveled edge works. You will have a stop valve. This is a stop valve to regulate the flow of carbon dioxide, and you have an opening or a channel through which CO2 can be insufflated. Now this Verey's needle is inserted blindly, right? This is a blind insertion. This is a blind insertion. So yes, there is a theoretical risk of injury happening when you're inserting the Verey's needle. Now, most common site where you're going to insert this Verey's needle is infraumbilical. But if patient has had previous surgery, if patient has had previous abdominal surgery and you're suspecting adhesions, in these patients, then in these patients, this is inserted in the Palmer's point. This is inserted in the Palmer's point, This has been given in Bailey. This is very important for your exam. It hasn't been asked till now, but can be asked in the future. So Palmer's point is 3 centimeters below. It is 3 centimeters below left costal margin. 3 centimeters below the left costal margin. In which line? In the mid-clavicular line. In the mid-clavicular line, 3 centimeters below the costal margin. So let me just show you a clip how the Verey's needle is inserted and how do we achieve pneumoperitoneum using the closed method. So you can see in this clip that my friend who's doing the surgery is making an incision at the Palmer's point. Why the Palmer's point? Because you can see the scars of previous surgery there. So he's making an incision at the Palmer's point and now he's putting in the Verey's needle. And you can see the Verey's needle. He goes inside with the Verey's needle. Now he's gone inside and now he'll check whether the Verey's needle is in place or not. Okay. So in the Verey's needle, I told you it has a beveled edge. So what happens is that it normally has a blunt tip. But when you put it against the abdominal wall, the blunt tip retracts. As you can see in this image, the blunt tip retracts and it cuts through the abdominal wall. Once it cuts through the abdominal wall, the blunt tip comes back again. So this is a safety mechanism that normally there is a blunt tip. When you put pressure, the blunt tip retracts. It goes in. As soon as it pierces the abdominal wall, the blunt tip comes forward again so as to prevent injury to the structures inside. So this is how a Verey's needle functions. And now they've asked in the exam that how do you know that the Verey's needle is in position? So how do we check the Verey's needle is in position? There are two methods. One is if I can put a drop of water here, I can put a drop of water at the opening and this drop of water is going to be sucked inside. So this is one way how I get to know that the Verey's needle is inside the peritoneal cavity. The second method which I'll demonstrate in the video. So you can see that the Verey's needle is in position now and we are injecting saline into it. Saline goes in freely. You can see that the saline column decreasing. It is going in freely. And if it goes freely, it suggests that it's in the peritoneal cavity and you cannot aspirate it back. So these are the two methods how we confirm that the Verey's needle is in place. Once we've confirmed this, then we are going to insufflate carbon dioxide, which I told you is at 1 to 4 liters per minute. Now the second method of creating pneumoperitoneum is the open method. This is also known as the Hassan's method. Now the Hassan's method is done under vision, right? This is under vision. We are going to make an infraumbilical incision. I will make an infraumbilical incision. And under vision, I will keep on dissecting till I reach the peritoneum. And under vision, I will incise the peritoneum and then I will start putting in carbon dioxide, right? So everything is happening under vision. So chances of injury are less. So chances of injury are less in this case, which is why this is used in patients with previous abdominal surgery. In patients with previous abdominal surgery, we are going to use this technique. We can also use the Palmer's point like I told you, but we can even use the Hassan's method. Now, these are the two ways of creating pneumoperitoneum. Once pneumoperitoneum has been created, we then have to introduce a trocar and then the instruments through it. So if you look here, there can be two types of trocars. This one is a Hassan's trocar or Hassan's cannula. And you can see here that the Hassan's cannula is a blunt cannula or a blunt trocar. So where is the utility of a blunt trocar? Is it in a place where there is no opening which I have created, or I have already created an opening and I can just put the catheter or the trocar through it? Of course, this will be used in the Hassan's or the open technique where we've already incised the peritoneum and then we put in this blunt trocar through it and we can put our instruments. But in the second method, where the Verey's needle was used, we have to use a sharp trocar. And this is what you must have seen in your colleges. You must have seen a sharp trocar like this, which is used to penetrate the abdominal wall and then go inside, and through this we can put instruments. So this is what the sharp trocar looks like. You can see it is pointed, and we are going to put it inside the abdominal cavity. Then we remove this and we can put the instrument through this trocar or sheath. Now let me just demonstrate a video to you how this trocar is inserted. So continuing with the same video, we have achieved pneumoperitoneum. You can see that my friend is demonstrating this trocar to you. The assistant and my friend, they will both lift the wall, right? And then he is going to, in a rotatory motion, he is going to push in the trocar. Now, what I want you to remember, this is very important. He is going vertically down, and only the first trocar is put blindly. Only the first trocar is inserted blindly. Rest all the trocars are inserted under vision once the camera is put in. You can see now that the trocar is in position. Now he's put in the camera. You can see inside the abdominal cavity. The first thing you check for is the site of entry of the Verey's needle. That is what you check if there's any injury there. And now all the trocars, all the other trocars would be put under vision. So here I want to share a very interesting story with you. It's actually a true story. So there was this first year postgraduate. You know that postgraduates join in June or July, and he was very excited to join surgery, and he joined the surgery department. But to his utter dismay, the first year for a surgery resident is just taking history, working up patients, doing dressings in the ward, putting cannulas. That is the role. Sometime which they get to go into the theater, they just hold the camera and they're just standing there. So they'll be asked to hold the laparoscopic camera and just show the thing. That is the only thing which the first year does in an elective OT. Of course, emergency OT, they do get some amount of work. Now this boy, for 6 months, he was just doing this ward work. Then he used to go to the OT, just hold the camera and stand like this. And he was getting really frustrated because of this. So one day he told his guide, he said, look sir, I'm getting frustrated. There's no work, meaningful work which I'm doing. And if it continues this way, I'm going to quit. I'm going to start preparing for the entrance exam again. Now the guide got really scared because the guide didn't want to lose a hardworking boy like him. So the guide said that next day, in all the laparoscopic cases, you will insert the trocars, right? You will insert the trocars the next day. So this boy was very excited. Next day he got up early. He had a hearty breakfast. He was all charged up and went to the theater. First case, he was asked to put the trocar, and he put it with all his might, and he injured the bowel, unfortunately. Right? So it went through the bowel. That meant no more surgeries for him for the next 6 months. But the question why I wanted you to know this story is that these things can happen. But what do we do if there is a bowel injury due to a trocar? If bowel injury due to trocar, what is to be done? I'll tell you 2 options and then I'll tell you the answer. Option number 1 is to convert to an open surgery but keep the trocar in position. Or option number 2 is to convert to an open surgery but first remove the trocar. Well, yes, the correct answer is we convert to open surgery immediately but keep the trocar in position. But keep the trocar in position. Why is this? This is for a few reasons. Number 1 is that the trocar which has gone through the bowel, it is sealing that wound, right? It has sealed that wound. If I remove the trocar, then fecal matter might start coming out and it will further contaminate the abdominal cavity. That is number 1. Number 2 is when you incise and when you open up the abdomen, you know the bowel is so long, small bowel is so long, And how do you know which portion did the trocar pierce the bowel? So even for localization, it helps if you leave the trocar there. This question has been asked twice in the All India exam. So I've told you the blunt or the Hassan's trocar, and I've told you about the sharp trocar as well. Another image which you need to remember, this is there in the latest Bailey as well. This is an opti port or a visi port. This is a recent advancement in laparoscopic surgery, opti port or visi port. Now this is like a trocar, but you can see here that it has a transparent end. It has a transparent end. So what is the advantage of this? I can put in my camera. And while I'm threading the trocar in, I can see where I'm going. So while inserting the trocar in, I know where I'm going. So this reduces the chances of injury. Reduces injury. And this is specifically useful in patients who are obese patients and those who've had previous surgery. And those who've had previous surgery, we can use an opti port or a visi port. So now that we've put in the trocar, after that we have to insert the laparoscopic instruments and carry out the surgery. Now I've explained these laparoscopic instruments in great detail in the instrument module, so you can even have a look at that. But you can see that these laparoscopic instruments are long black instruments and only the tip is exposed. So you can see here that they are long black and only the tip is exposed. And this black coating, why is there black coating? Why is it black and not fluorescent green or fluorescent orange? Because there's no glare. If it's black and you have the light source inside, there won't be any glare, right? So that's one. But this black coating is insulation around the instrument. This black coating is insulation around the instrument. And how is that useful for me? That if I attach the cautery here, look here, if I attach the cautery here, I want the current to only come out at the tip, right? Supposing at the tip I am holding a structure, I want it to work only at the tip. So that is why I've insulated the entire instrument. Now what can happen is that if this insulation breaks down, then current can leak from the instrument as well, and that can cause problems, right? So that is, this black coating is insulation. There can be various types of instruments. This one here is a Maryland's dissector with which you can dissect and you can hold the tissue. This is literally the workhorse of laparoscopic surgeons. Others are graspers, which can be toothed or non-toothed. I have demonstrated this in the instrument module, and you can have laparoscopic scissors as well. Now, like I was telling you, that if the insulation breaks down, what can happen? So understand this thing. My instrument is going through the metallic trocar inside the abdominal cavity. Now, there was a professor of ours who had an old laparoscopic set. He was about to retire, but he didn't want to change it. So in some of the instruments, the insulation started breaking off. Now, when the insulation starts breaking off, the current can leak from the instrument and it can go into the metallic trocar because the instrument is in contact with the metallic trocar. And the metallic trocar is in contact with the abdominal wall. So current leaks out from the metallic trocar and it can burn the abdominal wall. This is known as capacitance. So this phenomena is known as capacitance, where because of broken insulation, current leaks out, and goes into the trocar, which is metallic. And from the metallic trocar, it can burn the abdominal wall. Right, so there was a question which was asked in the All India exam 2 times in a row regarding capacitance, and they had asked, once they had asked what is this principle known as, and second they had asked how do we prevent this. Of course, I mean, if I ask you in the Viva, how do you prevent this? The obvious answer is going to be maintain insulation, which is correct. But is there any other way how we can prevent capacitance? Yes. Instead of using a metallic trocar, if we use a completely plastic trocar, plastic does not conduct current, and we can prevent this injury, or we can prevent capacitance. Now, another type of capacitance injury is known as capacitance coupling, or direct coupling, What does this mean? So, we've discussed that our instrument, the insulation is broken off, and we're using a metallic trocar. So now the current is coming to the metallic trocar. Situation number 1 is, supposing this metallic trocar is coming in contact with the bowel. My hand is the bowel. Supposing it is coming in contact with the bowel. So now what is going to happen? Current from the trocar is going to burn the bowel, and it can lead to a perforation. So this is one way of how coupling can occur, right? Another way of coupling happening is, we know that current has leaked out from the instrument into this trocar. Now supposing there is another instrument in the vicinity, and the tip of that instrument comes in contact with this. Now current is going to come from this trocar into this instrument, and if I'm holding some structure with this instrument, that will also get injured, right? So this is another way of capacitance coupling. I've explained you 2 methods. And how can I reduce this? Of course, by maintaining insulation, and also by proper triangulation. Remember, I told you one of the principles of laparoscopic surgery is triangulation. So if the 2 instruments are not colliding with each other, the incidence of this happening is going to reduce, right? So you should know about capacitance coupling. This is an important question for the exam. So now what we've done is, we have created pneumoperitoneum, we have inserted the trocar, and we have inserted the instruments through it. Now we have to actually carry out our surgery. Before I tell you about the various types of laparoscopy, I want to tell you one major advantage of laparoscopic surgery. So because laparoscopic surgery leads to faster recovery, leads to decreased pain. Therefore, because of this, laparoscopic surgery, a lot of laparoscopic surgery has qualified for daycare surgery. Now, what is daycare surgery? The name is self-explanatory. The patient comes in the morning, goes home the same day. They don't have to stay overnight. And it's because of the principles of laparoscopic surgery that this has become possible. In addition to the principles of laparoscopic surgery, we also use the ERAS principles here to ensure that the patient goes home early. You should know the full form of ERAS. I've covered this in another module as well, but I'll repeat it here. ERAS stands for Enhanced Recovery After Surgery Protocol. Enhanced Recovery After Surgery Protocol. Right? Now this ERAS protocol, what all does it include? So in the new ERAS protocol, only 6 hours fasting for solids is required, right? Traditionally, we used to make the patient fast for 10 hours, 12 hours, but the ERAS protocol says less fasting interval should be there. Even a 6-hour period is enough. And for clear liquids, the interval is just 2 hours before surgery. In fact, it is now encouraged that patient can take some carbohydrate-rich drink even till 2 hours before surgery, provided it is clear, and that leads to faster recovery after surgery. Other things in the ERAS protocol are that we don't put drains. Avoid drains following surgery so that there's less pain and the patient can be discharged. Post-operative nausea and vomiting medications are to be given. This is one of the commonest reasons why patient stays overnight, post-operative nausea and vomiting. So medicines for that have to be given preemptively so that this does not occur. There should be proper pain control. Proper pain control should be there. Liberal use of analgesics should be done. And also in these patients, early initiation of enteral nutrition. So as soon as the bowel sounds return, you start these patients. So in my patients, as soon as 4 hours, I'm giving them liquids. By 5.5 hours, they are on semi-solids after surgery. So this ensures that they recover faster. So early initiation of enteral nutrition and early ambulation. If these principles are followed, then the patient can be discharged early, in majority of the cases in the same day as well. So you should remember these ERAS protocols. They have been asked in the exam once. So these are the advantages of laparoscopic surgery, but there are certain disadvantages as well. So the disadvantages or the drawbacks of laparoscopic surgery. Number one, you get 2D vision, right? So that is a problem. The second disadvantage is that bleeding control is difficult. Bleeding control can be difficult. Right? So during surgery, if you see that a vessel is bleeding, in open surgery, you can just pack it, you can hold the vessel and you can manage it. But in laparoscopic surgery, it can sometimes be difficult. So how do we manage a bleeding vessel in laparoscopic surgery? So a bleeding vessel in laparoscopic surgery, we can insert a gauze through the port and put pressure. And we can put pressure. We can of course coagulate the vessel if we can see it. Otherwise, we can use topical hemostats. We can use topical hemostats like Botroclot. We can use topical hemostats like Botroclot and Surgicel. So this is how we control bleeding during laparoscopic surgery if there's a bleeding vessel. Another problem can be that there can be bleeding from the trocar side. This can be also a distressing problem. There can be bleeding from trocar site, right? So once you remove the trocar, you will see that a lot of blood is coming out from the trocar site. How do we manage this? So Bailey writes, in Bailey it is written that the best method is to enlarge the incision, and stop the bleeder under vision. Right? So you enlarge the incision and you look for the bleeder and you control it under vision. That is one method. Another method is you can insert a Foley's. You insert a Foley's catheter. So I put in the Foley's catheter through the trocar side. I inflate the balloon. You inflate the balloon of the Foley's and you hitch it up. So what is going to happen that the balloon will have a tamponading effect on the trocar site and the bleeding can stop. Right? So that is method number 2. And another method which has been described is that insert needles from the side and hitch them up. So I already have my camera inside. I can see that there is bleeding happening from the trocar site, right? We remove the trocar, we can see bleeding is happening from the trocar site. So under vision, what am I going to do? I'm going to insert one needle here, right? And then we can again take out this needle through another instrument and get it out adjacent to this vessel from here. And then I can hitch that suture up and this vessel will get ligated. So these are 3 methods to control bleeding from a trocar site during laparoscopy, and this can be a distressing problem. Another problem during laparoscopy, which I have discussed with you in the past as well, that there can be CO2 retention inside the abdominal cavity. And this CO2 retention, so if it is below the diaphragm, then what is going to happen? This CO2 can irritate the diaphragm and it can lead to referred pain to the shoulder tip. You know that diaphragmatic irritation is going to give rise to referred pain to the shoulder tip. And if you remember the first module where I spoke about the various surgical positions, and in the module on gallbladder surgery, laparoscopic cholecystectomy, I told you that during lap chole, the position of the patient is head end up, foot end low. You know, head end up, foot end low is reverse Trendelenburg and right side up and right side up. So in this position, all the gas goes below the right dome of diaphragm and it irritates the right dome of diaphragm and leads to referred pain to the right shoulder tip, which is the most common complication following lap chole. So this is another issue there in laparoscopic. And the final issue which is there in laparoscopic surgery is loss of tactile feedback. So what happens in open surgery is that I open the incision and I'm holding everything with my hand. So I know whether that structure is soft, firm or hard. But in laparoscopy, I am holding the tissue through this instrument, right? And when I'm holding it through the instrument, I'm not holding it through my fingers. So there is less information which I get whether the structure is soft, firm or hard. I do get some information, but not as well as in open surgery. Okay. So these are the major drawbacks of laparoscopic surgery which you should know about. So let's talk about the types of laparoscopic surgery now. The first one is conventional laparoscopy, which I've spoken about in a lot of modules. And conventional laparoscopy is that when we are inserting multiple ports. So if you remember when I was talking about laparoscopic cholecystectomy, I've told you that we insert 3 or 4 ports, and I've told you the details in that module of gallbladder. And after inserting those 3 or 4 ports, then we do the cholecystectomy. For lap appendicectomy, we were putting 3 ports. That also I have covered in the appendix chapter. Lap appendicectomy is 3 ports. Lap chole is usually 4 ports. And in lap chole, you know that the surgeon and assistant are standing on the left side. This has also been asked in the MCQ exam. Now this was conventional laparoscopy where multiple ports were put in. So for a lot of years surgeons were doing this and they were quite happy. But after a few years they got bored of this. They thought that, it's become such a mundane task to put in 4 ports and then to remove the gallbladder. So to spice up their life and to, have some more challenging things to do, they introduced single incision laparoscopic surgery. Right? So single incision laparoscopic surgery, or SILS, was the next advancement in laparoscopic surgery. This is known as single incision laparoscopic surgery. Now in single incision laparoscopic surgery, what happens? We make a single infraumbilical incision. We make a single infraumbilical incision which is 15 mm. And then we introduce this SILS port. This is a SILS port, as you can see. And this SILS port has 1, 2, 3 channels in it. So the advantage of the SILS port is that through a single channel, through a single port, I'm putting in 3 instruments. And through that single port, I can carry out that cholecystectomy, which I was doing with 4 ports. So that is the advantage, that single incision, so it is cosmetically better. But the drawback of single incision laparoscopic surgery is that it has a very high rate of incisional hernia. Right, so that is the drawback in these patients. Very high rate of incisional hernia. And another name for SILS is SPAS. Right? This is single port access surgery. single port access surgery, or SPAS, is another name for SILS. This is not the thing which you should know about. Now, another advancement which occurred was the usage of a hand port. Right? So, hand port, what was the utility of adding a hand port? We've already discussed that one of the drawbacks of laparoscopic surgery was loss of tactile feedback. We weren't able to hold structures and know what is their consistency. With the hand port, that disadvantage was eliminated. So you can see that you have your regular, you have your conventional ports which are there, and then this is the hand port where a seal is maintained so that gas does not leak out, and your hand goes inside and you can maneuver your hand inside, you can retract structures, you can feel them. So that overcomes the drawback of loss of tactile feedback. This is hand-assisted laparoscopic surgery. Now, surgeons again started liking these new advancements, but they started getting more demanding patients. And one such category were patients like models and people who were too conscious about cosmesis. They said that we don't want a single incision on our tummy when you're doing laparoscopy. So that was the challenge posed to surgeons, and that is when they came up with NOTES. So NOTES is again very important. In the last 4 years, there have been 4 questions regarding NOTES. NOTES stands for natural orifice. NOTES stands for natural orifice transluminal endoscopic surgery. Natural orifice transluminal endoscopic surgery is NOTES. Right? So what are the natural orifices through which we can go through? We can go through the oral cavity. We can go through the uterus. We can go through the rectum and the bladder. Right? So the first thing which I want you to understand, you're going through a natural orifice. So no umbilicus. Unlike other laparoscopic surgeries where our first port of access was infraumbilically, in NOTES we are not going through the umbilicus. Right? So not the umbilicus. This is very important. This has been asked in the exam. Now, oral cavity, what are the various NOTES surgeries which we've discussed in so many modules through oral cavity? We have discussed POEM, right? We have discussed POEM. POEM, you know, this is POEM. It is for achalasia cardia. It is per-oral endoscopic myotomy. It is per-oral endoscopic myotomy, which is done for achalasia. This was another question asked in the All India exam. You should know about this. Per-oral endoscopic myotomy. So we go through the oral cavity, and inside only from the inside we cut the muscle. We do the myotomy to relieve the achalasia. Then in bariatric surgery module, I have told you about TOGA, that is transoral gastroplasty. Transoral gastroplasty, which is a type of bariatric surgery. I've already told you about POSE. POSE is primary obesity surgery. Primary obesity surgery endoluminally. Endoluminally. This also I've told you. ROSE also we've discussed. ROSE is restorative obesity surgery. Endoluminally, this is done in those patients where you've done a sleeve gastrectomy and the gastric remnant swells up again, it distends again after a few years, then you can do ROSE. So all these through the oral cavity I've already discussed with you. Through the uterus, you can perforate the uterus, you can go in, remove the appendix, remove the gallbladder, you can get it out through the uterus like you deliver a baby and you just suture the uterus again. So no scar over the abdominal wall. Those are the surgeries which can be done through the uterus. Through the rectum, we have read about TATME in the rectal cancer module. I've told you transanal total mesorectal excision. Transanal total mesorectal excision is done through the rectum. And through the bladder, we can do varicocele surgery. Varicocele surgery can be done through the bladder. That is also a NOTES procedure. Advantage is that there is no scar over the abdominal wall, so it is cosmetically better. The final modification is the use of robotic surgery, and that is the latest in thing these days. And what you should know for the exam, that the robotic device which is being used is the Da Vinci robotic system. This has also been asked in the exam. It is the Da Vinci robotic system which is being used. Just to tell you that the company which had the patent for the Da Vinci robotic system, that patent is now over, and there are other companies who are manufacturing this robotic system. And you know that China is a leader in this, and once China floods the market with its homemade robots, the price is going to come down crashing. Right now it is very expensive, but in future the price will come down quite a lot, but you won't be able to remember the names because they'll be all Chinese made. So that is robotic surgery. Now what I want you to understand is that robotic surgery works on the principle of the master and slave concept. Master and slave concept, where the surgeon is the master and the robot is just the slave. So the entire intellect is of the surgeon. The moves which are being made are by the surgeon on a joystick, and those moves are just being replicated by the slave, that is the robot, inside the abdomen, right? So the master is the surgeon and the robot is just following commands in this case. The robot doesn't have the capacity to think and act, okay? Now, robotic surgery, you can see that the surgeon is comfortably sitting on this chair and he has these two joysticks in his hands and certain other controls. And when he moves them, the robotic arms start to move, right? So it's nothing, in some ways you can say it is an enhanced video game which the surgeon is playing. Now, what are the advantages and disadvantages of robotic surgery versus laparoscopic surgery? So robotic versus laparoscopic surgery. The advantages of robotic surgery over laparoscopic surgery are that you get 3D vision. This was a disadvantage of laparoscopic surgery. The second is tremor control, tremor reduction. So if the surgeon's hand has a tremor, the robot is going to negate that tremor, and that tremor will not get carried on to the robotic movements as well. So that is another major advantage here. There are more degrees of freedom, more degrees of freedom. So in reality, there is 7 degrees of freedom, 7 degrees of freedom which robotic surgery offers. And I was taking a class once, and one of the students asked me that by this, do you mean that the surgeon who's sitting on a chair can get up and go to the toilet in between the surgery? No, that's not the freedom of movement which I'm talking about. The freedom of movement which I'm referring to is that when you're doing laparoscopic surgery, this is your only movement, right? This is the only movement which I can do in laparoscopic surgery. This is the only movement. But robotic surgery, the robotic arms moves like our normal hands, right? They move like our hands. So you can go in any which direction, and by doing this, we can do even fine suturing and delicate dissection. So that is a major advantage. And another major advantage is scaling of movement. Now, what exactly do I mean by scaling of movement? So if I'm doing open surgery and if I have a needle holder in my hand and if I move my wrist 180 degrees, the needle holder also moves 180 degrees, right? So same amount of movement is occurring there. Similarly, in laparoscopy, if I move the instrument 180 degrees, the instrument moves 180 degrees. But in robotic surgery, I can put in a command that if I move my wrist 180 degrees, I just want the robotic arm to move 30 degrees. Right? I just wanted to move 30 degrees. So I've scaled down the movement. And by scaling down the movement and having more freedom of movement, we can do fine dissection and suturing. So that is an advantage. Fine dissection and suturing can be done in these patients. What are the disadvantages of robotic surgery? The biggest disadvantage is it's very expensive. I just explained to you. Second, there is a longer learning curve. It takes a longer time for the surgeon to master this art. And third, there is loss of tactile feedback. right? We've been discussing about tactile feedback, and we said that tactile feedback is reduced in laparoscopic surgery, right? Open surgery, we are feeling everything. Laparoscopic surgery, I'm holding the instrument in my hand and feeling through the instrument. But in robotic surgery, you can see here that the surgeon is not holding the instrument also in his hand. In fact, there have been case reports where the surgeon is sitting in Annapolis. Annapolis are the US Naval headquarters close to Baltimore, and the patient is being operated on a US submarine somewhere in the Atlantic Ocean. So the surgeon is not even there in the theater, let alone holding the instruments. So when he is not holding the instruments, there's absolute loss of tactile feedback. And this is one of the major disadvantages of robotic surgery. Now, robotic surgery is not feasible for all procedures. So where these days are we using robots? So robotic surgery is being used for robotic radical prostatectomies. So robotic radical prostatectomy, this is one of the surgery where they found out that robotic surgery is actually better. Then robotic radical hysterectomies or pelvic surgery is being done. A lot of oncological surgeries are being carried out using robots because you get fine dissection and fine suturing through the robotic arm. So this was regarding the module on minimally invasive surgery. I've told you it's a very important module, not only for final year students, but also for those who are appearing for the entrance exam. So you should not skip this module. You should remember each and every point of it. Before we end, just a couple of questions. Which one of the following is not true regarding laparoscopic trocar placement? In Vary's needle technique, only the first trocar is inserted blindly. I showed you the video. True. Optiport is useful in patients with previous abdominal surgery. Yes, this also I told you, this is important for your upcoming exams, Optiport and Visiport. SILS has a very low incidence of incisional hernia through the port site. SILS is single incision laparoscopic surgery. I told you very high incisional hernia rate, false. And if there is a trocar injury to the bowel, the case should be converted to open. This is correct. But what is the prerequisite? We should keep the trocar in position so that we know what is the site of injury. During lap chole, true and false, surgeon and assistant stand on the left side. This is true. This we've discussed. Lap chole is safe during acute cholecystitis, provided the patient comes early. We have discussed this, that if the patient comes early, the first 72 hours are the golden period, and you can carry out surgery in that period. Position is Trendelenburg and right side up. False. It is reverse Trendelenburg and right side up. Head end is up, foot end is low. Right shoulder tip pain is the most common complication following lap chole. This is also correct. So this was regarding the module on minimally invasive surgery. Thank you.